that nobody is paying attention to what is a patient's need. See, patient comes to me with a stroke or the head injury, I remove the clot, I do something, I said, you're cured. He's not cured because the scan is cured, but he is still having problems. You have things like the kidney function test, liver function test, heart function test, thyroid function test, everything else, but there is no brain function test. So I came up with a concept called C2C. The C2C for brain is called coma to community. From a person who is deeply unconscious in a stage of coma, all the way back to where he can go 10 levels. Same thing for spinal cord, C2C, from the cot to the community. So it's just a simple idea of screening, land up with a screening tool which calculates the C2C level online. And that screening tool is called the SEFA, S-E-F-A. SEFA is self-evaluation of functional abilities in neuro patients, SEFA. This is an online self-assessment tool which is hosted on our website, and it's called rebootingthebrain.com. You go to there, you can answer the SEFA. SEFA consists of 700 plus questions, statements across 18 different sections. Sections related to diagnosis, to consciousness, to tubes, to upper limb movements, to lower limb movements, to turning in bed, to brushing, to memory, to vision, to hearing, to everything at the end of the day. So on an average, a patient and a family or a caregiver may land up filling between 90 to 120 questions based on their problem. There's an AI behind it. So when they enter that, and now we have connected that report to our Microsoft Teams channel we have. The report comes here. It says C2C BIR3A, C2C BIR2B, automatically comes. So the first thing is we have a self-assessment tool to calculate the C2C level, which is the starting C2C score. The next question people ask is, will my father get better? Will he walk? Will he talk? Will he get back? It's the question I asked myself is the patient rehabable? So once I asked myself the question, is the patient rehabable? I came up with another question they wanted answers for. How much is he rehabable? Where will he end? ಎಷ್ಟು ಮಟ್ಟಿಗೆ ಆಗತ್ತೆ doctor? Because they have to spend money. They don't know what to do. So then I came up with this idea called a rehabability index, RI. So the RI consists of only two things, the C2C score and the duration of the test, that what we call. By calculating that, you can actually get the possible projected C2C outcome. So I'm having a starting point of C2C. I'm able to predict what is the possible thing. And today, we've been using this for the last 5 years. We're in the process of publishing it. We're having 70 to 85% accuracy in that. The RI tells the possible exit C2C, the possible duration of treatment, the number of sessions per day, and the type of facility. Does he have to get admitted in a hospital? Does he have to come from home, somewhere else? That all depends on the cost, duration. So the family gets a lot of data and the possible percentage of success. I'm not saying 100% success. Some of them we say only 30%, some of them we say 50%. So that's what is the first level of our patent, which is defining the starting point and defining what is the possible ending point projected. This leads to the next question that you asked me, which I also mentioned in the past, is about the software, which is the Logix software. Now all of us know neurological disorders. The neurological spelling is Neurological. I have converted that to Newrologix. So it is Neuro's logic. That is the logic of Dr. Sharan and his team. We objectified subjective data. So we got some method in the madness. So we started understanding now which direction is my patient going, what's going on. So at least I know now to communicate to the family, your patient is in a bed mobility level 2, we are heading towards 5. They understand now. Your child is in standard 2, is going to standard 5. How many more stations in the metro? You understand what's happening. So you get these intermediate milestones that's coming in. Everybody knows there's a plan. Every plan has an effort. There's a money involved in that. And now we have put that whole thing, which was now on paper pencil stuff and Excel sheet and Word document stuff, into a software. And that software is probably the world's first rehab operating system. We call it the ROS, R-O-S, rehab operating system, which also has, it's an ERP, enterprise stuff, and it has billing, and it has HR management, and managing the patient sessions and everything else. But that's what we are going to launch in the next 6 months. And after this, it's going to be a game changer, because then we can go globally. I can control what's happening to my patient somewhere else by sitting here. We can see data real time, see the videos, the reports of patients, and I'm telling you, it's really going to change the way neuro rehabilitation is delivered and neuro disability is looked at.
So ROS has two big areas. One is administrative and a clinical. So the administrative part, you know that typically how the administration work. Now the biggest challenge is how this clinical module and the administration module talk to each other. So if you come to the clinical part, the biggest challenge what we are facing in rehabilitation is you have multiple professionals: physical therapist, occupational therapist, speech therapist, psychologist. These are all like 4 different people talking 4 different languages: Kannada, Malayalam, Tamil and Hindi, something like that. If all these people talk, you cannot get one information, right? So people are not understanding what they are telling only. So the communication is not very clear. So this is how I am seeing ROS is something which is talking the same language. That so what we have done is we have converted all these domains into one outcome, that is patient's functional independence. We call it functional independent level. So what it is actually doing is now it is talking to each department and it is suggesting you what is the next goal you have to work on. So the therapist need not to worry that what should I work on. All these things are preset, and at the same time we are all working towards same direction.
There's so many things our patients need, innovations, For example, if a patient is lying in the ICU, the foot movement has to be done. There's so many things. I already have about more than 100 ideas that we have to create. So we have to run our own engineering company step by step. We're trying to do all of that. But a couple of things we have done already is a rehab treadmill, for example. Now, a rehab treadmill is not available made in India. Because what's the only difference between the regular treadmill and the rehab treadmill is, rehab treadmill has to go slowly. This is going kilometers per hour, this has to go meters per hour. So thanks to Harsha from Mysore, he built a rehab treadmill for me, and we are building it at 1/3 the cost. It's like that. And we have still got 2 prototypes. Now we've got some learnings from that. We are trying to build the 3rd one and then look at commercializing it. It worked very well. Patients are extremely happy. They can see that they can get into a rhythm of walking, slowly getting into the treadmill. The treadmill goes forwards and backwards. The other thing we have built is something called a body weight support harness. So it's initially when the patients have had a stroke or a weakness in the leg and they can't stand on their own feet because their legs are weak. What happens is normally when they're made vertical, there's somebody holding on this side, somebody holding on that side, then with the hand around their neck or something, and then patient is wobbling and standing. And Murphy's law, one fellow is taller, one fellow is shorter and taller, and they're the patient is standing like this, and if the patient is 90 kilos, by the time they lift up, the caregivers are having back pain, so many things, and sometimes the patient can lose balance, and then he's got this fear of falling. Some of them have fallen, and now once they fall to our neuro patients, they will never get up again. This fear of fall, in fact, we run a fear of fall program for so many elderly people and neuro patients who have this fear of fall, having already fallen or know somebody else who has fallen. So so there's a concept called body weight support harness that's available in the West, quite expensive. So we built our own body weight support harness, which is called Walk Free. It's just a prototype right now. So we have a lot of things in the pipeline that we want to do, both using VR, AR, and also using softwares and things like that for games to rebuild the circuits in the brain and things like that.
We find that now, number one, we've realized that we've done the right thing all these years, over the past years, to get involved with this team. And well, we still believe that this is just the beginning. There's a lot of ground to be covered in the future. So we will keep on, as a hospital, as the management of the hospital, we will continue to offer whatever assistance we can and offer whatever facilities we can to this particular team of neuro rehab as well as neuro surgery. Okay, because from neurosurgery, we also get patients from functional neurosurgeries and stereotactic surgeries that come in who had, a lot of problems with Parkinsonism, with movement disorders, and then they are operated, they get all right, but they still need to be rehabilitated because their pre-operative conditions were so bad that, they couldn't just come back to normalcy without a rehabilitation program being structured for these patients. So each patient undergoes a program that is structured entirely individual for the patient's need. So a lot of evaluation goes on before the rehabilitation program is started, and then it continues throughout the rehabilitation program to make amendments, to make changes, to make deviations as per the requirement of the patient and as per his capability of coming back to normalcy, which I don't think is there in that measure in other institutes. I don't know. I mean, I'm sure they are doing a good job, but I can only speak about my institute, and I can speak about the Rehabilitation Center and the Neurosciences Center, and I think they're doing a damn good job.